the office or something like
People go to, yeah, then it can just like pause it or stop it. In the downtown, it's so much. I think. Yes, then there you go.
Okay. Processes and cool.
Great, well, enjoy your meeting.
Well, thanks everybody for coming today. Sorry, we're doing this new live streaming with the PHAB meetings, which we haven't done in the past, and it's pretty complicated technologically wise, but we'll get it down. Lots of steps involved. But anyways, yeah, we're gonna just start off. Glad that people were able to grab some food and sit down and chat, and then I think we can just transition to the Health Heroes Award presentations. And what I asked is we have Eric Brion here who's going to take some pictures, and we're going to for a social media post that we're going to have later on today. And what we will do is have the persons who nominated the heroes come up with them and the award, which we'll ask our chairs, Rob and Colleen, to present. And the person that nominated them will read the reason why they were nominated. So, and you want us to come up here then? Yeah. Yeah. Guess it won't quite get in the photo, the camera up there, but anyways, yeah, if you want to just pick out, I guess, either the individual or the.
Well, I'll pick the one on top. So that's the organizational award that goes to. I guess we should take these out of the covers. This is always the funnest meeting of the year. It is. It's like wonderful to recognize individuals and organizations in the community that have made a significant contribution, the most significant contribution to public health. And the first award for the organization goes to the Partners in Care Transition Team.
Wow, there's a lot of you. Who's nominated to hold this?
And co-chairs, get in there with them. You're supposed to.
nice and tight.
Make it official. All right, 3, 2, 1. Okay, great.
Okay.
And if you could introduce yourself.
Yeah, hi, I'm Maureen. I'm the Communications Director and Veterans Outreach Coordinator at Partners in Care, and I work with these amazing women every day, especially to support veterans in our community. And so I'm gonna read what we wrote, but then, say a few other things. And so the Partners in Care Transitions Team has been transforming the lives of medically fragile individuals across Central Oregon since 2004. So it's been almost 20 years that we've had this program. 5 transitions coordinators, Bethany Benefield, Lori Sly, Molly Denton, Holly Andrews, and Pam McConnell, who's not here right now, cover a 10,000 square mile area from Jefferson and Crook County through Deschutes County and all the way out to Christmas Valley. They help clients and families navigate resources that many are not familiar with. This results in people not falling through the cracks or feeling alone. Many are isolated or have minimal support from family. And the team works very closely with numerous organizations in Deschutes County to include county health services, social workers, the Department of Veterans Affairs, Veteran Service Officers, the VA clinic, the vet center, unhoused resources, senior centers for Meals on Wheels, and more. The transitions team is instrumental in providing resources, lists, and education that helps so many in the community. Daily, this team supports over 400 people across the Tri-Counties, touching thousands of lives each year. Bethany Benefield is qualified as a Medicaid assister and supports transitions clients applying for Medicaid benefits in navigating that process. Pam McConnell on the team is also well-versed in veterans issues and can direct veterans in the community to necessary resources for benefits, healthcare, and other assistance. Many clients that we've worked with have said, what would I have done without them? And many families who live miles away have shared how appreciative they are for regular check-ins and resources for a loved one. And this is a non-medical program that is completely at no cost to everyone that we serve. And that's something that's really special about this team is, you know, Partners in Care finds a gap in the community and addresses that gap, and Transitions really meets a need in this community for medically fragile individuals. And we do it because we're a nonprofit, and these women do God's work every single day out in the community. And so we're really excited for this and very grateful to have them every single day out supporting people who might not otherwise have someone to look after them.
Thanks, you guys. Our individual award goes to Brad Porterfield.
In the middle here.
There, thank you.
Carmen.
Yes.
I don't know. Basic formalities, okay.
All right, ready, 3, 2. Got it, thank you.
Do I get to say all the
You get
beautiful
to,
things?
you get to say all
Why
the
nominated?
things.
So I'm very new to Central Oregon. And Brad was one of the folks that has sincerely not just welcomed me, but continues to welcome the community. He had run as executive director, the Latino Community Association for 17 years. And I think that alone is an accomplishment. And as that organization has grown, I could see all the services that folks don't normally have in the Latino community. And first, when I thought of Health Heroes, you know, is it something about physical health that you need to be part of this? And it's not. It's about having a healthy community that's supported, that has the services. Their organization does advocacy, which did a lot of support for the new PHAB initiative that's happening now. And, you know, I kept seeing him everywhere. And that's the other thing too, is when I first started, I knew somebody from the Willamette Valley area and said, you need to connect to Brad. And I said, okay, I think I have a meeting with him this week. And then I went to my first board meeting and he sits as a chair on the board and he was there. And everywhere in the community, I would see him continuously be present with the most vulnerable. A lot of times I think there's decision makers that are not embedded that way in community. And I did see Brad in that space. Then I went to the Latino Fest and he's like, oh yeah, we run this every year. And I'm like, okay, what else? What else do you do? So, so anyway, I just wanted to recognize him. And I'm sure a lot of you support this as well as a health hero for this year.
Nominees this year, we would love to have more for next year's award, and congratulations again.
But any interest, we have a great presentation coming up in a little bit, so. Sorry, okay. Thanks for coming.
Thanks, you guys,
Thank you so much.
for all your work. You can take seconds with.
Yeah.
We have-
You did. Yeah, I did.
The fun part. The fun never ends.
Yeah, it doesn't. Okay, so I
So, yes, so should we have people introduce themselves?
yeah,
People in, and,
probably should, actually, I didn't think probably should have done that when the words were going on.
yeah, it's okay.
Oh,
I'm Rob Ross, I'm the chair. Colleen will go this way.
I'm Colleen Sinsky, Vice Chair. Wow, that's a lot of people.
Yeah, so no, almost 25.
Carmen Madrid, Executive Director for Central Oregon Health Council.
Peter Baum, retired pediatrician.
Lindsay Atagi, clinic or changed positions recently, and I'm still not used to the new title, like community quality coordinator.
I'm Steve Strang, CFO at Mosaic Community Health.
Oh, I'm Greta, I'm just taking the notes.
Matthew Christensen, epidemiologist in health services here in Deschutes County.
I'm Dr. Olson, I'm Chair of the Behavioral Health Advisory Board.
Welcome.
With you.
Logan Clausen, the Chief Medical Officer of Central Oregon Pediatrics.
Bill Chang, Deschutes County Commissioner, liaison to the PHAB.
Ruth Bernardico, Executive Director at Aspen Ridge Memory Care.
Tom Kuhn, FAB Coordinator, and if we could head over to the wall.
Sure, Laura Hart, Public Health Management Analyst here at the county.
Rich Fawcett, Health Officer for Deschutes County.
And Dr. Fawcett will make his best efforts to come to our meetings when he's able to. So,
Our state meetings are conflict, but that changes, so maybe I'll get my.
yeah, Dr. Fawcett has been with health services for a long time and his role has expanded recently. So we thought it'd be good to have him as part of this group to bring his experience.
Absolutely, welcome. All right, moving on. Did anyone read the minutes?
Yeah, I apologize. They were sent out pretty late this week.
And if so, could I get a motion?
Make a motion to approve.
Thanks, a second.
Second.
Any modifications or changes that anyone wants? If not, we'll approve them. Okay, thanks. Announcements.
Well, I did say to Maureen from Partners in Care that there's a fall conference they have going on October 13 called Solutions for Complex Realities in Post-Acute Care. So I have some of these little flyers. I'll pass them around, and if anyone's interested, please attend. She thought it'd be nice to have some people from this group, so I'll pass a few around if anyone's interested. Any other announcements? Open general announcements? Anybody have?
There is a walk this weekend for Oregon Recovery. Anybody? Actually, I have a team on PHAB. A team to join to come walk. You can find it on their website, Oregon Recovery.
I don't see it on the minutes or on the agenda. I'm wondering if at some point, either at this meeting or in an email, someone can speak to the current COVID levels in the county.
Yeah, sure. We can always, anytime if you want an update on any topic related to health, just let me know. We can get someone there. Yeah.
Anecdotally, I've just heard a lot of people getting it, and I'm wondering what that looks like from a global perspective here.
With that on the October agenda.
I wasn't here in August, so maybe this already said, but I'm gonna say it anyway, for the fellow pediatricians and vaccine proponents in the room. The RSV antibody was approved for all newborns, and maybe this is like not news to most people, but just like huge win from at least from my standpoint of really keeping kids safe. So we will be giving all newborns qualify. So during RSV season over the winter, we'll be able to give newborns a antibody that protects them against RSV. So it's not ongoing primary immunity, but covers them for the season, which is very exciting.
Yes.
A huge, like monumental step forward, in my opinion, for public health.
And hasn't the vaccine been approved, the RSV is it approved for pregnant women and the elderly? I can't remember.
Elderly for sure. I think there's still some discussion of pregnant is my understanding. Not
Okay.
I'm now speaking vastly out of my scope. So I would say
It's okay, just the elderly I wanted to bring up.
that one is for sure. Yes.
Huge number of people are admitted, well, quite a few, especially last RSV season. It was monumentally large numbers of people were admitted with RSV. So it's the infants and the elderly. Very important.
But it's gonna be administered by pediatric practices, not the hospital.
That is my
Story.
understanding. That is my understanding. It's actually across the nation probably going to be that way. It is, most hospitals are not set up with VFC, which is the vaccines for children. It is a complex process that takes a lot of like monitoring, reporting. It's a huge headache. Most of them do not do it and eat the cost. This is my understanding. Again, I feel like I want to really clarify. This is my understanding from an outside perspective, not part of the hospital. And like, so feel free to correct me if anyone has other information. Very complex, and they typically just eat the cost of like the hepatitis B vaccine that's given around birth because it's expensive. And this is not the same. This is quite expensive, would be challenging to eat the cost as part of a normal newborn delivery. And getting set up not only in time for November, which is when sort of season starts, but even in general is so much of a process that would take too much logistical barriers is my understanding. Bare minimum for this year, but my guess would be ongoing. And I think that's what across the country, most places, I think that's what's happening. Yeah. Even larger ones are just not set up for VFC. Yeah. They could then choose to, they could choose to do private, because that's much less of a, they're set up to do private insurances clearly, but then that's like you're offering it for some people, not the others. And that.
All right. Meetings are being recorded. Tom.
Well, I've already mentioned that a little bit as we were messing around up front there, but just from now on, all PHAB meetings, whether in person or virtual, will be recorded. And normally there will be a live stream. Something didn't pop up for me that should have popped up to link to live YouTube. So we're going to try to figure out what that is. But anyways, just knowing going into the future, that will be the norm for the PHAB meetings. And that's something the county has implemented across all boards and committees that they have that are open to the public. So just wanted to share that.
I'm sorry, they're both live streamed and saved on the PHAB.
Yes, this meeting will just not be live streamed, but it will be saved. It'll be saved on the commissioner's page where all the other meetings with the county are listed. So anyways.
All right.
Yeah.
Bylaws update.
Yes, just wanted to let everybody know, we did some work on the bylaws. We, during the August meeting, the group reviewed some of the major changes that were made, which were in the scope of the work for PHAB. A lot of it was wordsmithing and just updating. So we just concentrated on that area. And anyways, they were reviewed by legal. And so at this point we can, maybe do one final review and then go to the commissioners for approval or edits. So we'll let everybody know that's where we are in the process.
And we're doing the same thing on behavioral health board. Jessica wanted to tell you that she did get that information for you. That we weren't sure where we are in the process. Or we doing that.
Yours were already approved.
Were they?
Yes.
Yeah, it was about time we updated our bylaws.
Yeah, it seems like every 3 to 5 years the bylaws update.
We were a little late.
Yeah, that's something going
That's
on.
okay. We had some stuff going on, which brings us to our next topic. Commissioner Chang and I want to recognize Steve Strang's service to the committee and the PHAB and various community things. And we want to.
I just learned that Steve is actually terming out.
Yes.
I thought he had a lot of other things to do, but which he does, but he's actually prohibited from serving on the PHAB for more than eight years without a special extension. Which I guess all of you can look forward to it. Yeah, we wanted to recognize and thank you for your service. As many of you know, that Steve has been he's been with the PHAB since 2015 as a member. and provided great insight and, thoughtfulness and curiosity, and a wealth of healthcare knowledge through the group in the time that he's been with us. Things that we want to particularly recognize Steve for are, number one, be just the tremendous role that he played in coordinating COVID response efforts, not just locally here in Central Oregon, but more broadly for the entire state through the whole pandemic. And then for your service on the PHAB, always being a strong advocate for immunizations, public health, the role of federally qualified health centers. So thank you for contributing all of those things to us, to your community, and to the state of Oregon.
Thank you. Appreciate it.
The bylaws update does contain, if you've changed it from already served 8 years to 10 years. So.
No escape. And when 10 years comes around, it'll be 14.
No, it's been, I don't know, it's been great serving, especially with the folks who've been on PHAB. I've really enjoyed it, and the work that the county public health team does is just immense and critical. So thank you guys for having me. Appreciate it.
And thanks especially for the role during COVID, like that cost you a lot of years of life.
This is a special time.
Hopefully never to be repeated.
I do think it's really unique, like you bring, there's very few like financial people that can do what you do. And I think it's really unique the way you like merge mission, vision, heart with like finances. I think it's really cool. From like across the table, consistently on board meetings, I think it's really cool. Yeah.
Thanks. Now you can relax.
And Steve actually recommended a mosaic replacement for his position, so we have an application.
So you guys should consider that.
We are.
Yeah, they were invited to this meeting, but maybe she couldn't make it or something.
Yeah.
Yeah, but she's invited to the rest of the meetings. So.
Okay, Matthew. we have
Yes.
A presentation by is
I have it
at the front.
ready to go on the computer up here, Matt. So. Okay. One of the things I need to share the screen. Yeah, let's do that. Ask for a little bit of sting. So. Yeah, go ahead, Matt, and take it away. Okay. Introduce your presentation.
I'm just wondering if can you stand up here? I suppose that'll work. I'll grab a seat as well. About drug overdose in Oregon. So I have seen all the headlines, and I'm sure you have seen the headlines that drug overdose mortality rates are high in Oregon. We are now in a drug overdose mortality crisis in Oregon. However, beyond the headlines, I haven't been able to get information about where drug overdose mortality rates are high and how high are they. See if I can move this.
Can you minimize it?
A little better, yeah, that's good. And so, needing and wanting to get a clear information about drug overdose mortality in Oregon and here in Central Oregon. I had the opportunity early this year in April and May to work with an intern from Oregon State University, Charlotte Ladley. And we met weekly during those 2 months. This helped to complete her master's MPH program and Master's of Public Health degree in the public health program at Oregon State. And it helped me and us here in Oregon get a much clearer picture about drug overdose mortality, what's happening around us, and what we look like in relation to what's happening around us. It's relevant information to see where we're at specifically, but then in comparison to what's happening around us. So that's this presentation today, the results of this study. We identified 2 to 3 drug overdose mortality hotspots. Multnomah County and Portland first and foremost, Lane County and Eugene. And that southwest corner, including Josephine, Jackson, and Klamath counties as well. Those are the main results I'm going to talk about more in depth, the hotspots and the spread of drug overdose mortality around those hotspots. And then several communities experienced a spike in drug overdose mortality. We're finding a spike in terms of going from low rates to high rates. Communities that did not have high rates and in a short period of time, 1 to 2 years, they had a large increase in drug overdose mortality. This is the big picture, looking over the past 2 decades, and the title says drug overdose mortality rates for the United States and Oregon. Starting on the far left, going back to 2000 and up through 2021, drug overdose mortality rates per 100,000. The blue line is the United States. The orange line is Oregon. And I want to focus, and the majority of what we're going to be talking about is this and particularly these 2 years. In 2 years, 2020, 2021, and we have preliminary data for 2022 that shows this same increasing trend. 2 years, our drug overdose mortality rates more than doubled in Oregon. Prior to 2019, follow my cursor, here in 2007 up to about 2019, we were relatively stable. That's our history here in Oregon for a long time. Not a lot of change, up or down. This is hovering around 11 drug overdose deaths per 100,000 during this time period. Relatively long time period. I'm going to talk a little bit later about what happened here in 2011, why we separated from the US, what was happening down here with prescription opioids, and then what's happened and then how it's associated with this steep increase here in Oregon. I don't know if I can minimize that guy. It's okay, I can tell you what the title is. Looks like I'm going to be losing the title on a lot of my slides, but we're gonna, these next 3 maps, these next 3 slides are looking at maps of the state of Oregon. This is for 2019, then we'll look at one that looks identical for 2020, and then identical for 2021. Again, at the end of the presentation, we'll talk about 2022 data. It's preliminary, it's not final yet. The drug overdose deaths, a sample is sent to the toxicology lab, and that test result sometimes takes weeks and months to return. And the delay then in the death certificate data coming back around, we'll know our final data for 2022 later this year, at the end of the year, or even the beginning of 2013. But we do have a pretty clear picture based on the preliminary data that was reported last month by the Oregon Health Authority that this increasing trend is continuing in 2022. But for these slides, this is 2019, the next one is 2020. And then we'll look at 2021. We've set them up so that they're all the same. This is the legend, and you can probably see it maybe good enough to where you're at. We've split it into 4 categories, and these are rates per 100,000, death rates per 100,000. Counties that are in the yellow. Looks a little bit bigger on the big screen, but and then gold is the second category, rates from 13 to 19. Purple is third, rates from 20 to 30, and then red, counties that had rates of 31 or above. We didn't have any counties in the state of Oregon until 2021 above 30. So there aren't any red counties until we get to that 2021 map. Here in 2019, this is right where we were at the end of that 13-year period. This is what things looked like back then. And the majority of our counties are yellow or gold. I do want to mention all of the counties that don't have a color assigned. The majority of drug overdose deaths are in that population center, highlighted by those counties in color. 90% plus of all drug overdose deaths are along that corridor where you have counties with a color assigned. All the counties that don't have a color, there were fewer than 10 drug overdose deaths in that county in that particular year. And we can't calculate rates when the numbers get too small or rates start to fluctuate. It doesn't give you an accurate picture. And so we're only calculating rates when the number of deaths were high enough. But it is important to note that that is 90+%. That's the majority of those counties that, yep, go ahead.
Sorry, just to point out that the yellow is 1 to 12, right?
It is, yeah.
So less than 10, would that not show up in the counties that have no color? I was wondering, I mean, if you had 2, you could be in yellow, or if you had 2, you could be not with any color at all, right?
Yeah, so it's, if I understand your question, the differences between numbers and rates. This map is for the rates calculated per 100,000 population in that county. And so if that county had too few number of deaths, we don't calculate
less than 10 total. Sorry,
less than 10 in that county, right?
Sorry.
For example, you're right. Yeah, Jefferson County, Crook County, for example, in addition to many other counties, has less than 10. Yeah, and we trying to calculate a county rate doesn't work.
Some of those counties are very, very small.
Yeah.
You know, 4,000 people, something like that. So, I mean, if you counted, if there was 3 in a county of 4,000 people, it'd be like off the charts in terms of but.
Yeah.
Well, I'm assuming if you had, you could have 8 or 9 and still have a rate that.
There are several counties with 7, 8, 9. Absolutely.
It might be, fruitful.
Yep. No, they were. That was the thing is, if it was a really small total population and they had 7 or 8 deaths, they had a really high rate. And it just starts to fluctuate too much. And it just, statistically, it just breaks down. The take-home message is that the majority of deaths are in those counties where there was a color and we were able to calculate rates. However, I certainly don't want to, speaking broadly for the state, most counties, not all, most counties saw an increase in this in the last 2 to 3 years. And when we see that steep increase in 2020 and 2021, and it's continuing through 2022, nearly all counties have seen an increase during that time. We did here in Central Oregon, Deschutes, Crook, and Jefferson. Our numbers of deaths increased. There were 4 counties that had some of the lowest population levels that had no deaths in any of these years. So there are some of those counties that were a 0, but that was just 4 counties. The overall picture is the number, our rates have really increased. There are certain areas where it's increasing rapidly. And then through a lot of other parts of the state, when you get away from these hotspot areas, then it's increasing at a more gradual rate. This next slide for 2020, you'll notice that we have less yellow and a lot more gold into that second category of rates. This is 2020. And 2021, where 8 of the counties had a rate above 31 deaths, drug overdose deaths per 100,000. I'm going to talk a little bit about this slide and go back and forth between a couple of slides. The main results of this study that we did earlier this year focused in these 3 areas: identifying the hotspot regions, which I've talked about a little bit, and I'll talk about a little bit more. The B, letter B. The primary increases were in those hotspot communities, but also around those hotspot communities. Not all of those communities increased at the same rate, but you can see around Multnomah County, a lot of surrounding communities in 2020 and 2021, their drug overdose death rates increased substantially from where they were in previous years. The way I'm defining a hotspot is for here in Oregon, if these are communities going over several years, and these are the areas where drug overdose mortality rates have been high most years. These are the communities. And then the letter C, these are communities where that's been low, and then in primarily in 2021 and in some cases 2020, they had a dramatic shift from low to high drug overdose rates. So I'll just point out those hotspot regions, and I know you're all familiar with them, but in terms of geographic location, Multnomah County had a rate of 42 drug overdose deaths per 100,000. First and foremost, year in and year out, Multnomah County has the highest drug overdose rate in the past several years, or nearly. I'm going to talk about Curry County a little bit later. In 2021, they had the largest spike in the state, a really small county, small population. They had twice, their rate was 89 per 100,000, twice as high as Multnomah County. That usually doesn't happen. It's almost Multnomah County far and away has the highest number and the highest rate. Secondly, Lane County, consistently over the past several years, they also are having some of the highest drug overdose mortality rates, with Eugene as the main population center. And the reason I say 2 to 3 drug overdose rates, it depends on how you want to look at this bottom southwest corner. If you want to include all of this together, you could think of it as 2, but this is such a large geographic area, a lot of smaller communities. I kind of like to think about it as 3, but it doesn't matter. I would like to actually get more information from people in that area that could speak to, oh yeah, we're all together. This is something that's really shared, or if Lane County looks very different. If it is 3, it would be Multnomah County, Lane County, and then you've got Josephine, Jackson, and Klamath. Over the past several years, those are the areas that are always rising to the top in terms of rate. There's some fluctuation year to year, but those are what we're talking about as hotspots in terms of drug overdose. Where did this happen? The increases were in these hotspot regions and around those areas, as I've talked about. So this is 2019, the map we just looked at in 2021. Portland and Multnomah County. And you can see that Columbia didn't have enough in 2019 to calculate a rate, neither did Yamhill, and we've got rates in all of these counties at 8, well below the state rate in 2019. And so across all of these 6 counties, Columbia, Washington, Yamhill, Marion, Clackamas, total number of drug overdose, 301 in 2019. 2 years later, it was 706. Columbia County had a significant spike. In an earlier presentation, we looked at Google Maps to see if we could see anything just looking down on population. A large segment of population, this is a smaller populated community, but a lot of it is right there on the border, not far from Portland. They have several smaller towns right there in Columbia. And so that gives you an idea of the spread around Multnomah County. In that southwest corner, this is what the rates look like in 2019, and in these two coastal counties, there were less than 10. We didn't calculate rates. In total, 143 drug overdose deaths in this part of the state, and then it more than doubled in 2021, 333 drug overdose deaths throughout this southwest corner. So when we're talking about the hot spots and spread around those hot spots and what that looks like in epidemiology, speaking broadly, one of the things we always want to try and understand is disease transmission. How is a disease transmitted? For example, we're just coming through, we're still in some degree, coming into the fall, COVID-19, but in 2020, early on, I'm sure you remember one of the primary things was figuring out how is this transmitted? And it took a while, but once we settled in on airborne, then we focused on, okay, maps and social distancing as ways to at least start to disrupt how that is interrupt how that disease is transmitted person to person. This is a very different application of this epidemiology principle in terms of spread and how we can interrupt it. So thinking about it from a supply and demand perspective, law enforcement is largely working on the supply side to interrupt drug overdose mortality, federal in the country, outside the country, state and local law enforcement. On the demand side, public health, a lot of us and our agencies, healthcare services, this is recovery, treatment services, a lot of potential different strategies on both sides of this. I wanted to include that because that's part of what this data can help us understand in terms of seeing things more clearly. And when we see this spreading across Oregon, wow, what can we do about that? This is difficult to stop, very challenging on both the supply and the demand side, but there are things we can do and they have success, and that's where we can focus. Letter C, spikes in drug overdose mortality. There were several communities. The ones I'm going to focus on here are the clearest examples of a spike. And the way, as I mentioned previously, in terms of defining this, counties that previously for several years had low rates of drug overdose mortality, and then in a short period of time, 1 to 2 years, they increased dramatically. I've already mentioned Curry County in this southwest corner. I think their total population in Curry County is around 23,000. Their rate in 2021 was 89. More than 2 times higher than Multnomah County. Another spike community was Columbia County, right here on the northwest border. They had a rate almost identical to Multnomah County in 2021. Marion County saw their rate more than triple in 2 years, in 2020 and 2021. This is Salem, our capital in Oregon, in Marion County. They saw a spike in drug overdose deaths. They didn't end up in 2021 above 31 deaths in this highest category, but they came from relatively low. And for them, it was a very rapid increase in Marion County. And then interestingly, out here on the northeast border, this is Umatilla County, including Pendleton. They saw a moderate spike. This is where I-84 is kind of at the halfway point between Boise and Portland, going across the Columbia River Gorge, and it comes down through Pendleton, Union, Baker, into Boise. And all of 3 of these counties, the numbers in these 2 counties were too low to calculate rates, but once I saw where these 3 counties were on the map, and they were all contiguous, they all had increases in this 2-year time period. Whereas a lot of these other eastern counties didn't see consistent, clear patterns of increases, or at least not contiguous counties. So I want to now give you a little bit of a comparison and talk about us here in Deschutes County. We have seen our drug overdose deaths increase. And it's not insignificant by any means. It's going to look insignificant here in a minute. But I think it's relevant to see where we're at. Our numbers of deaths nearly doubled in 2 years as well. We went from low to higher, but relative to what's happening around us, our rate was 6 in 2019 and it increased up to 11, nearly doubling in 2021. But nowhere near where Portland was and is now, or was in 2021. That's in each one of those years, that's about 3.5 times higher in terms of the rate in the population. That's Lane County. And then that southwest corner, Josephine, Douglas, Jackson, and Klamath. So it gives you a little bit of perspective. We are not a hot spot for drug overdose mortality. We haven't been, and we haven't really experienced a spike like other communities, but our numbers have increased. It's something that we are watching closely and working right now, recently with our medical examiner to start to get timely drug overdose mortality data so we can identify if our numbers start to increase more rapidly, like some of the other areas that have happened in Oregon. If we put Curry County on the map, you know, down in the southwest corner, I didn't put it on the map because it would really send the wrong message. It'd be twice as high as any of the other counties. And it's certainly relevant. You want to understand that what happened in Curry County was very unexpected, but it would just dwarf everything else here. And that's just not an accurate representation. Columbia County would go from low to high as well, having a similar rate to us here in Deschutes in 2019, to then going up to where Multnomah County is in 2021. I want to talk a little bit about the drugs. These are data for 2020 and 2021. And starting off on the far left-hand side, any opioids. There's two main classes of drugs that are coming back positive on the toxicology test results. Opioids and stimulants. They're the most common drugs in the drug overdose death data. Starting on the left, in 2020 in the blue bar, in 2021 in the orange, you can see 67 and 68% of all drug overdose deaths were positive for an opioid in those 2 years. Yeah.
To be clear, this is just positive test result. This isn't necessarily the reason for death.
It's both. These are drug overdose deaths. So on the death certificate, it's what was the underlying cause of death? What was it that? So if they're in that, we can't say that an opioid was specifically, it's broadly that drug overdose death category, but if there was an opioid, it has to do with proportions of drugs in terms of if you want to identify, but I'm not sure if that's helping with your question or. Yes, this is the cause of death. If there's a drug, we're talking specifically about drug overdose deaths. They died from a drug overdose. We don't know it changes person to person how much opioid was positive. That is shown on the toxicology test. It will give you the drug and then the amount. And so you can kind of decipher and say, oh yeah, that was clearly an opioid because the rate is so high on that.
And then people who overdosed who had both opioids and stimulants in their body.
They're both represented here. Yeah, this is more than 100%.
That same person would be on both charts.
Yes. Yeah, we're talking about percentage on this. We're just simply talking about drugs, wanting to see which drugs are coming up positive. Yeah, it is. Yeah, that would be both. Yeah, we're just talking about drugs, not people now.
And then they don't distinguish between what they think was the main cause of death typically. So they just know that there was heroin and meth. And they'll always distinguish in terms of the cause of death. That's correct.
Yeah, on the cause of death form, the medical examiner has to decide what was that underlying cause of death that led to the sequence of events that ultimately led to death. Right, and it was a drug overdose death. Everything we're looking at here, all of these numbers, they concluded this was either an accidental or undetermined drug overdose. It was not an intentional suicide drug overdose. These are accidents or undetermined intent. So the three most common opioids that are coming up positive, out of this two-thirds of all drug overdose deaths were positive for an opioid. Fentanyl, heroin, and prescription opioids in these years. You can see the relative proportions of those drugs. Moving over here to stimulants, 57% in 2020 and 63% in 2021 were positive for a stimulant. And then the two most common stimulants, cocaine and methamphetamine. So you can clearly see that specific drug classes, methamphetamine and fentanyl. I've got a big box around this, so I'm going to talk about this just for a minute, and also the next slide, which relates to this. But this spike of drug overdose deaths that we're seeing in the state of Oregon, it correlates to what we're seeing with fentanyl. In 2019, I don't have it on this chart, but in 2019, this comparable percentage was 14% of deaths were positive for fentanyl. So we would have been somewhere around here. 14% in 2019, 32% came back positive in 2020, 48% came back positive in 2021. We have seen preliminary numbers, not final yet, for 2022, and it suggests that we're going to be well above 50% with fentanyl. And I don't know where, mid-50s, or if we will get above 60%. But these are big steps every year. As we're seeing our drug overdose rate increasing rapidly, it's strongly associated with, and I know this is not a new message for any of us. We've been hearing this in the United States for a long time, but this is relatively new for us here in Oregon because it's just been the last 2 or 3 years. And that's what I want to talk about on this graph. In this first decade, 2000 up to 2011, we're tracking with the United States. This is when prescription opioids primarily was driving the increase in drug overdose deaths. When I put this slide together, I remembered back when I first learned about this, some 20 plus years ago. I remember, and some of you might too, hearing about Miami and seeing reports of why are people lining outside pharmacies down in Miami, and they had nightly news, and there were people outside the door of the pharmacy, down the sidewalk, around the corner, and multiple pharmacies. That was my first introduction back then of wow, what's going on, and they started piecing it together. And then we get to 2011 and things change. And there have been a few studies as to when fentanyl and what fentanyl looks like coming into the US. And it associates with this time period. Some of the East Coast cities, Boston, Philadelphia, West Virginia, major metro areas in the South and the East started seeing increases in their drug overdose deaths in these early years. CDC published a report that looked at regions of the country during this decade. And you can see in the West, compared to the East, parts of the East and Central and South, there wasn't anything happening in any of the Western half, almost the Western half of the country. Fentanyl was not coming up positive, not just here in Oregon, but a lot of the Western states. We started to see fentanyl in our death certificate data, a few percentage in 2017. And then I've talked about in 2018 and 2019, it was about 14% were positive for fentanyl. And then we get our increase, which is our fentanyl starts to come back at a higher rate every year. Last month, Oregon Health Authority sent this publication out, and it was the first information I had seen for 2022. 2022 data are not final, or else I would have it in the presentation. They're preliminary. We're not going to know the final numbers. So the numbers here, they're going to increase. They probably won't increase a lot at this point. We're almost 3/4 of the way through this year. And so, but these numbers for 2022, which currently as of last month, we're at 934, probably will increase a little bit. We're only looking at opioid overdose deaths. So remember when we were looking at the drugs, this represents about 2/3 of the pie. When we're talking about the overall percentage of 100% of drug overdose deaths. So for opioid deaths, representing about 2/3 of the total. In 2019, opioid deaths was 280, 472 in 2020, 737 in 2021. And now our count for 2022 is 934. So this didn't end in 2020, didn't level out, didn't go down. It's continuing on a very similar trajectory upward. My last slide, these first two just reiterate what I've been talking about, in that we are in the middle of it. This is still going on in our state, and we've looked at places where it's been high in 2020, 2021. It's not always the same year in and year out. The rates do fluctuate a little bit in some of the areas. There are some areas that are consistently high, like Multnomah County and Lane County. They've always been high. But some of those southwest corner counties, they kind of fluctuate a little bit. They tend to be on the higher end. For us here in Central Oregon, our numbers have increased, as we've talked about. To end on a positive note on this, recently we have started to speak with our medical examiner's office to get access to timely drug overdose mortality data. So far, we have not experienced a spike in drug overdose deaths in Central Oregon. But we don't want to identify it 6 months later or a year later and say, oh, look, we did experience a spike. And we have confidence now because the data clearly show it. We want to be able to hopefully identify it early enough to where we can respond and start to meet some of that demand when it's happening. That's in process, and hopefully in the near future, we'll have a easy way for them to report that data to the health department, and we will be able to start to track the numbers. And if we do see an increase, then we'll be able to respond. Thank you very much for time at your PHAB meeting today. And if you have any questions, I'd be happy to try and. Yeah, go ahead.
I'm just racking my brain trying to figure out what the correlation is between those counties that are hotspots. Do you have any idea what the reason is?
No, I don't. That is right. It's a spread. I will relay a conversation that I heard from someone I think probably has some great local knowledge. It was a meeting in Crook County with the public health director there and one of the staff, and it was and some of you probably know this gentleman. He's the director of the codes effort here in Central Oregon. I'm sorry, I don't know his name, but I'll relate to you what he told us in that meeting. He said that recently Oakland represents based on the West Coast for fentanyl distribution, and they have a pretty secure base there. Portland has now become a base of distribution, and when I heard that, I thought, wow, the data sure support that. He said there's also Seattle, and he mentioned a couple of other major metros, Salt Lake and Denver, as places in terms of distribution where they're seeing that it's a pretty well established network. That's certainly going to be associated partly with what's happening in terms of that secure distribution and where that happens. I can't speak to, and it's a question for me. That's why I say 2 to 3 hotspots. Does Lane County really fit in that southwest corner, or are they separate from Josephine, Jackson, Klamath counties?
What's being done epidemiologically to confront or kind of describe accidental overdoses? Because I imagine a lot of the opioid overdoses are actually accidental, given fentanyl contamination to other drugs.
Question?
Yeah, so what is being done to kind of track that? That's my question. Is there anything being done to track that? What accidental overdose?
So all of these are either accidental, so they're determined to be unintentional. There isn't any evidence or sufficient evidence to say that it was an intentional overdose, so it's determined to be an accidental. And then there are a few, and it is very few usually, that are in this middle category of undetermined intent. If they're not sure of, well, we're not sure if this was an accident or if it was intentional, they go into this undetermined intent category. There is a national tracking system supported by CDC. It's state unintentional drug overdose reporting system. Oregon does participate in that system. They are currently abstracting data from all of the drug overdose deaths in the state, and they reported it as a national system, but there is that in the state of Oregon. We don't have access to it here. They're looking at police reports and medical examiner toxicology test results. But when we are able to, moving forward with our medical examiner here, and we're also working on the law enforcement as well, we'll be able to at least be able to track the numbers of deaths, most importantly, just to see if we start to see that increase. Yeah. So we're doing that locally. I'm not sure if I'm answering your question or not.
Yeah, I guess I understand the definition of accidental, but I'm just curious. Like accidental based on contamination, like people who were doing a drug thinking it's cocaine, for instance, and then it's laced with fentanyl. Like, what are we doing to track that?
Yeah, as far as I know, nothing. That's very hard to determine in terms of if they thought they were taking a different drug, they didn't know fentanyl, or as far as I know, I've not seen any studies on that. I've heard, that as a common issue, and it is, I think, an accurate interpretation of drug overdose deaths that oftentimes people aren't sure what's in there. But in terms of a data system that's tracking it, I don't know of anything in our state or in other states.
This isn't an exact direct answer to Ruth's question, but I just wanted to mention that if people are interested, particularly in opioid deaths and particularly in kind of the role of fentanyl in the last couple of years, the county has received, will receive over a 16-year period about $7 million of national opioid litigation settlement money. And Janice Garceau and Jessica Jacks and our community justice director, D.B. Holcomb, just did a presentation for the Board of Commissioners. They've been trying to help us come up with an allocation of how those funds are going to be spent for like 4 or 5 months. It took a very long time for my fellow commissioners to kind of get on board with a plan. But they did a really good presentation just, I can't remember now whether it was last week or the week before, but that's all recorded, just like these PHAB meetings are going to be recorded from now on. And the presentation was probably like 30-40 minutes. That was very complimentary to what Matt has presented today.
It is complimentary. I worked with a little bit and supported that presentation. So it provides a lot more detail on the strategy and response slide. I had that one slide that talked about the supply and demand and public health. They went into that public health and healthcare side in terms of how those dollars could help on the prevention, treatment, recovery side. There's much greater detail.
Yeah, it was really digging into like, well, how do you interrupt these cycles of opioid overdoses?
And real quick, in terms of, I think, state support funding, there are fentanyl test strips. Maybe you're thinking of that. And I don't know what you've done locally for that. That's something I think will be useful. It's probably not regulated as to how they're used, but so that users can figure out if there's contamination with fentanyl. Because a lot of these overdoses, it's not just, if it's fentanyl, it's not only fentanyl that they're finding in the doctor, right? So that is one way that might be a resource down the line to help protect the public.
Is there anything, I'm really interested in the differences also in the counties that have high rates but lower population. And the only third thing that I would be interested in your slides, you talked about the supply, the demand and then the supply. But my only other thought would be like access to care, like access to Narcan, access to interventions. And so is there anything that we're seeing in some of those regions that I'm gonna make assumptions about, but maybe is it accurate? Like maybe they have less Narcan availability per, like a rate of Narcan availability, or rate of speed of 911. I don't know, like I'm making up the data points, but like.
I'll overlay another conversation or another conversation comment I had when I first gave this presentation. It was to the 3 public health directors and several other staff here in Central Oregon, and the 2 public health directors in Crook and Jefferson County, they noted, wow, what happened in Curry County? And the other one responded, they don't have a distribution program. They didn't have Narcan. They didn't have, it's such a small, it is a small, that there isn't a public health agency in Curry County. And so
Every county is gonna get these opioid settlements, so they
I think
can
that's good.
choose some of these overdose prevention strategies.
The state kind of feels that some counties that are prepared for overdoses by having a Narcan allocation program have less of a spike. So that's, I don't know if that's been proven, but if you have some Narcan that's available, the spike.
It's this, I'm curious with, you kept mentioning, Crook and Jefferson are too small.
Yeah.
Population wise to do. How are we in Central Oregon? If they were added, what color would we be in the Tri-County area?
yeah, we're still in that yellow category where we are in the lower category. But there has been an increase. If you look at 2019, 2020, 2021, in all 3 of our counties, our numbers have increased. The total number of deaths, though, is still putting us in that lower rate in comparison to what's happening around us. If you were only looking at our counties and that was all you had to look at and you saw it increase, it's a clear and a meaningful increase in rates, nearly doubled here in Central Oregon.
One other thought though, when you're showing, and Umatilla County.
Yeah.
And talk about I-84. Umatilla County is more associated with Tri-Cities in Washington.
I saw that. There's metro areas right across the border. Yeah, right.
A lot more, and then the Blue Mountains, Union County and Baker, Mount, you're more associated with Idaho.
Oh, okay, okay.
Having lived over there.
More associated with what?
Idaho.
Has anybody looked at how much Narcan you have to have around in an area to make a dent on death? And does that Narcan, should I be carrying Narcan around? Or should somebody that hangs out in Lapine at Wickiup Junction, should that be a place where you have a lot of Narcan available?
So I don't have data on Narcan distribution or Narcan usage. I can say broadly speaking, though, Narcan is being used frequently in Central Oregon. And it is when someone is unconscious and suspected drug overdose, and they are often coming back. Sometimes they're reporting 5, 6, 7 doses of Narcan before they come back. So it's active. It is currently being used. I can't speak to you.
It expires every 6 months.
The Pain Standards Task Force has been really involved with, which I sit on, has been really involved with Narcan distribution in the tri-counties, which might be one reason, and it's used really frequently.
It could be.
The other observation is, like, I lived in Klamath Falls when methamphetamine came on the market many years ago. And it's interesting because the spread of the fentanyl is the same as methamphetamine. You moved from Klamath County, moved along the highway 97, then over to Eugene, same thing as this. Right, I think it has a lot to do with the distribution.
I do too.
Network.
Yeah, that makes sense.
Is data being compared in any way to measure 110? Seems the timeline of it seems to maybe correlate. Is there any considerations about that? That ballot measure, that measure has affected these rates at all?
Oh, if it's, can you clarify that a little bit more? The association?
Yeah, decriminalization of drugs, and if that's increasing utilization, causing more death rates, I'm not sure.
When was it passed?
Timeline wise, I think that was on the ballot in 2020, and that's also when we're seeing those steep increases, and I wonder if, I don't know, this data has been looked at across the nation with other states that are possibly going that direction with decriminalization, if you can see that same.
So we think it was passed in 2020 in Oregon?
I think it was proposed 2020. For sure. About right.
Yeah.
Well, it's certainly the same time frame. I haven't seen any study that, but I've heard of similar comments, so I don't know.
On a reflection too, I'm like Mount Hero County, that's where I hail from. I know there was a lot of resistance in utilization of Narcan, thinking that it would just promote usage. And so I know that was something we battled a lot over there, is making sure that it was in the hands of just your everyday individuals, because you might have a sheriff that's gonna take 45 minutes to get to the location, and by that time.
Yeah. I think it makes sense to support both Narcan but also encouraging more long-term treatment recovery services and access to long-term recovery plans.
Is this data being described as illicit and self-administered? So there's no malpractice in here, right?
The data I shared with you are death certificate data. I'm not sure.
Yeah, I'm just wondering if it's folks who died from self-administered illicit drugs, or if there's any medical issue there.
Well, we know, what was it, 10–12% of the drug overdose deaths were positive for prescription opioids. But that's as far as we know. We don't know if it was their prescription or
I think that in general, the overdoses that are with prescription opioids tend to be illicit use, so stealing or whatever. And then if it's an overdose with somebody who actually has a prescription, typically that's a suicide more often than not. I mean, they can overdose unintentionally by taking too many painkillers with, a painful diagnosis. But I think typically, if it's prescription drug overdose and it's illicit, it's usually people who are using it recreationally.
Yeah.
I think I'll take the chairman's prerogative and we're gonna have to move on, but thanks so much, Matt.
Yeah, you're welcome.
Me and I definitely, if things come up later on. Thanks, Matt. All right, Colleen. You can share.
Something.
No, that was a tough act to follow. I feel like I could.
You can just give a quick update.
I'll just do really quick, and this is positive, so that's nice. I could watch or learn about that all day, so. I wanted to just talk briefly about solutions to homelessness. We're actually working on some programs that are working, and it's kind of exciting to be able to share about this. The promised title was our Housing Barrier Busting Fund, but I did want to give an overview of how that fits into our two other programs. So again, I'm the Executive Director of Central Oregon FUSE, currently the only full-time staff member, but I'm hoping that'll change. And we're working with partners across sectors to address homelessness. For each of the participants, we're always working on permanent housing. We're not transitional or emergency shelter, it's always permanent. We're especially targeting folks who meet the HUD definition of chronically homeless, which means that somebody's been unhoused for a long period of time and has disabling conditions and probably complex care needs. Those folks who are likely to remain homeless without an intervention. We're doing that across 3 programs. First, support services coordination. This is a mock-up of Cleveland Commons, which is a 33-unit, will be a permanent supportive housing development coming to Southeast Bend. I've been working on this project for almost 5 years now, and we're finally about to break ground in 2 weeks. So Housing Works is the developer. Neighbor Impact is going to be the largest portion owner through a joint partnership between the two. Mosaic and Deschutes County are on board as partners. And among other things, Central Oregon's first purpose-built permanent supportive housing development. But it's really this amazing pioneering effort and collaboration between these entities. Fuse kind of exists at the hub, so I can like speak just enough about affordable housing finance and just enough about healthcare systems and HIPAA to be able to bring the partners together and the funding streams together. But happy to share more about that at a future time. Next is our neighborhood-based housing program, which is a different model of permanent supportive housing, where we're supporting folks by paying ongoing rental subsidy and providing in-home case management, and that's throughout the community.
Who's paying it? Who makes the payment?
We do,
Who's-
yeah, and it's using HUD or Housing and Urban Development funding, specifically through their Continuum of Care grant.
Mhm.
So a lot of what we're doing is like braiding these like complex federal grants with more flexible local money to build the different elements of the program.
Are those grants continual or one time?
They're annual and kind of expected to be renewable. It's always a competition.
Okay.
And what's the target?
Target population for both this program, I'm sorry, and the one that I just mentioned, Cleveland Commons, is folks who meet that chronic homeless definition. It's people who have been assessed by the coordinated entry system and have scored high enough to have like the highest vulnerability according to a handful of different risk factors. I'm really happy to report that we've got 100% of people still in housing. Ask me again next month and hopefully that won't change. But it's really affordable, actually, just $47 a day, which is about the same cost as emergency shelter. And that's for rental assistance, case management, healthcare connections, and like the portion of like program organization management.
I know in like several other cities that I've lived in and known of, scattered sites have not really been successful for the community at large or for the neighborhoods that they were in. And I'm wondering how long we've been doing that project here and like how it's affected the neighborhoods surrounding.
So I think you might be thinking of purpose-built, because scattered site is like we have one person in this apartment complex and one person in this apartment complex and then one over here. Like the property manager knows that somebody is getting half of their rent paid by an organization and a third of it paid by the individual, 2/3 and a third. But otherwise the neighbors don't generally know. So it's different in that people aren't concentrated. It's kind of like that distributed throughout the community. So folks do have to be able to pass like a standard rental criteria screening. At Cleveland Commons here, we're gonna have, I think this is the question you're getting at, as far as like in this building, like there will be 33 folks living there who do have vulnerabilities related to like why they became homeless or conditions that developed while unhoused. And this, like, we're working on putting together a good neighbor agreement and working with both law enforcement, EMT, the neighborhood association, and the neighbors right around there. I really think that this is going to end up being a net positive for the community because it's 24/7 building access secured. And it's 33 residents who are going to be there for the long haul as opposed to like a high transition shelter or something.
Awesome.
And the only next door neighbor to this is actually like a power substation.
This is the same, this is the same kind of that they have in Gresham. It's called Rockwood Rising. And they developed that. I did some work with that with the small businesses, but they basically have a market hall, you know, to support small businesses and affordable food and fresh vegetables locally for these types of residents. But it's not just for, they wanted to make a profit out of it. So not all of it is low income housing. And then the other side is all services like childcare, healthcare, workforce development. So it's pretty cool. So it sounds like the same thing. And the neighbors around, at first they were like, oh, we're gonna be gentrified out of here. And then we started to talk to them. I said, no, keep your house because the equity is gonna go up in it. You know, so they, you know, that was a way for people to sustain and support this model. And it was paid for by the city. It was like the city and the county combined. It was pretty cool.
Yeah, I can share the funding details about this at another time, but it's supported in part, or I'm sorry, about Cleveland Commons. But county ARPA dollars, City of Bend, affordable housing, SDC waivers, construction excise tax. Yeah, there at least like 10 different funding sources have gone into that, both for services and brick and mortar development. Then last is our newest program, the Housing Barrier Busting Fund. And this is a pilot that doesn't actually exist in other communities that I know of, but essentially Fuse is the steward of a community pot of money that pretty much any local nonprofit agency or healthcare agency that's serving the unhoused population can access that fund for their clients' needs related to getting into housing. So it's a very simple concept. We don't work directly with clients for this. We rely on agency level MOUs and to work with case managers. That also means we don't need to get releases of information. So we're getting information about what's needed from the case manager, then we make the payment directly to the third party. So these are some of the frequent barriers people experience.
Who supplies these funds? Is that HUD supplied as well?
No, HUD is so their funding is a lot more limited in what it can do. So this relies on more flexible money, largely coming from the healthcare system, specific source, Central Oregon Health Council. There's a small grant from the realtors, and it's primarily that for now.
Okay.
Yeah. So healthcare primarily.
Expected to be renewable.
Hopefully. Yeah, and again, like the goal for this is season again.
I don't know how this could be of benefit to you, but I just joined the board at CAMP, which is Companion Animal Medical Project. And if there's anything that we can do to help with any of these barriers in regard to pets or.
Yeah, and I'm in touch with Johanna as far as like for that. You guys save your money for like more pet specific things.
Beautiful.
Yeah. What did cut you just time? Should I?
Well, you know, I almost feel like we should have you come back again at some point too. It seems like there's a lot of interest in this and didn't really give you the amount of time you should have had. So,
But yeah, whatever folks want. I was here. I'll have more data next time too.
Any preferences?
More time. More time.
More time.
So Colleen, are you looking at the medical costs of people that you serve?
That is that's like the $1 million question.
Literally.
Yeah. So FUSE acronym actually stands for Frequent User System Engagement, which relies on a very data heavy model looking at folks who are accessing like law enforcement services, frequent arrests, frequent ER visits, frequent stabilization center. What we've learned is that not only is it super hard to get that data, that even to get like a snapshot point in time of that data cost Multnomah County like a ton of money to get a snapshot from like 3.5 years ago. That's static and not super helpful for decision making. So I try to avoid using the FUSE or acronym because we can't quite adhere to that model, which really would give us a very concrete, definite picture of the cost savings before and after housing, kind of as a proxy to get at least like the healthcare side of things. We work with Pacific Source and like looking at the back end of their data around utilization costs. We're still kind of in like the brainstorming element, trying to figure out vulnerability, social determinants of health assessments that we can administer kind of longitudinally for participants, and also looking at the utilization rate without breaking privacy, confidentiality. So it's all kind of we really want to make that happen and look at the cost savings associated, and it's hard to do. And I welcome conversation with anyone who has good ideas. I've got really smart folks on my board, and we've got great partners. But yeah, always wanting to talk to folks who are experienced in that.
I wonder if to add or complement to this conversation is, you know, bringing COIC, Tammy Bainey, because they're stewarding those funds.
Oh
to
yeah,
build.
we're one of the MAC.
I'm on MAC too,
recipients.
but I'm wondering if like the rest of the group here would want to know an update on all that. So.
Yeah, I love giving updates.
Excellent.
all right. Yeah, sounds like you over.
We'll invite you back for 2 hours.
Great.
We're gonna solve it in 2 hours.
Yes, it'll all be fixed.
Yeah, if there's anything in the meantime that you want to hear like more about related to any of this, feel free to let Tom know or let me know, and I can try to incorporate that.
Thank you so much.
Thanks.
Thanks.
Yeah, thanks for
coming.
heroes and take some food to go.
Yeah.
Yeah, we never, and we always over ordered them, man. We even ordered less than there were. people.
Really?
Oh,
well.
Yeah, help.
Your guests didn't hold up their end of meeting.
I know.
Thanks for everything.
See you, Ruth. It's been a while. Yes.
We nominated for the board.
Yeah.
Crazy.
So the thing is, we're
medical.
just have to have between 10 and 15 minutes. We can,
And one of the screenings of these.
we're at 12 right now. We have 3 seats open. However. It's in between the. I think the most members we've ever had at once was like 13. Yeah, it's always been. Yeah, thanks.
It's more like.
Yeah, see you around.
Like when someone's in, like offering, offering connections to resources, like there's gonna be like a strong policy.
Thanks so much for taking this.
Okay.
Yeah, Amy will come back and clean it up.
Originally.
All that stuff, but.
It's still really kind of all there and survives without that. But it kind of starts with like stability.
I think also maybe addressing treatment, are they in treatment?
Yeah.
That's a good time to kind of make sure they're.
Right, and then to have like on the site, a meeting, well, that's, yeah.